The Falling Walls Science Breakthrough of the Year 2022 in Life Sciences. Breaking the wall to treating rare genetic diseases. How a new therapy is improving lung function and quality of life for cystic fibrosis patients. Markus Mahl, Charité, Universitätsmedizin Berlin.
On November 9th, 1989, I happened to be in Berlin and was standing next to the wall.
Thank you. Thank you. I'm really honored to be here today and receive this award, and really pleased to talk to you about a breakthrough in a therapy for rare genetic disease, cystic fibrosis, which remains one of the most common rare genetic diseases worldwide. Before I start, I want to acknowledge this has been a work of many people over the last 20 years, and I really want to thank my team at the Charité, but also our collaborators at the German Center for Lung Research, the European Clinical Trial Network, our industry partner, and many others who have contributed to this with critical steps. And I also, to give you an impression of the clinical problem and the problem of the patients, want to start with this picture and tell you what patients often say when they are asked how they experience the disease. And they often say that it feels as if the lungs are filled with water that actually makes every breath a struggle, and that it can feel like drowning from the inside. So on the next slide, I want to show you what the problem is, what makes breathing so difficult. And as you can see here, in healthy people, the airways are open to allow, when we breathe in, airflow into the lungs, whereas in cystic fibrosis, the airways are obstructed with mucus, as you can see on the right side, causing airflow limitation, and that is what makes breathing difficult. However, we found that this is actually not the only problem making breathing difficult, but that too much mucus in the airways, because it is a very nutrient-rich source or very rich nutrient for bacteria that we inhale all the time, also forms a nidus for chronic bacterial infection. That is a trigger for chronic inflammation, which destroys the lungs over time, making breathing even more difficult and also leading to early death. I here want to show you a sort of historic development of life expectancy. What you can see is when the disease was first described clinically, about 100 years ago, hardly any child affected by the disease reached school age. And then we're able to develop therapies that target the symptoms of the disease, so chest physiotherapy, inhalation therapies that help to clear the mucus, and also advanced antibiotics to treat the infections. And as you can clearly see, this has substantially improved the life expectancy and quality of life. And now in several countries, we have actually achieved a median life expectancy of around 50 years. So that's already very good, but it also comes with a high burden of treatment, as you can see here. It means, often taking many pills per day, doing hours of inhalation, and despite this intensive therapy, many young adults with cystic fibrosis, as of today, still had substantial limitation of their lung function. As you can see here in the longitudinal lung function measurements of Eva Bonsack, who's one of the patients treated in our clinic at Charité, that is in the range of 30 to 40, 45%, which is way below what we consider the lower limit of normal, that you can see here as 70%. And Eva kindly shared a video with us to show you what this level of impairment of lung function meant to her daily life when she was trying to exercise and had problems following her 2-year-old boy.
Edgar, nicht so schnell. Mama kann nicht so schnell.
So I think this really demonstrates there is a high unmet need for better therapies. And here the cracking of the genetic defect, the identification of the cystic fibrosis gene and its protein by investigators at the University of Toronto in 1989, actually just a couple of months before the Berlin Wall fell, was really one of the first key discoveries that from the beginning led to hope that it will one day be possible to treat this devastating disease at its root cause. And what they also found at this time, that there's a spectrum of defects, of mutations in this large gene, but there's one hotspot in a critical region of the protein that you can see here that is called F508del, and that is present on at least one allele in about 90% of patients with the disease. By that time, it was not known what the function of the protein is and how this mutation causes the disease. So that was actually the next big question. How does a genetic defect cause cystic fibrosis? And here we and many others, by studying airway cells in the laboratory, were able to show that the protein in healthy people forms a channel that is inserted into the surface of airway cells, where it plays an important role in salt and water transport, which is essential for normal mucus properties. So the mucus is a very important protective barrier that entraps and then also clears bacteria out of the lung. And in cystic fibrosis cells, we found that this delta F508 mutation causes a misfolding of the protein, so that it's actually recognized by the cell as a wrong protein and degraded, so it never gets to the cell membrane. It cannot act as a channel, and that leads to a dehydrated and highly abnormal and sticky mucus that cannot be cleared from the lungs. Now that's kind of theoretical, but to show you what this means in practice, I brought you these pictures of mucus from a healthy and a person with cystic fibrosis. And what you can see, the healthy mucus, when you put it on a glass surface, spreads out and forms a thin film. This is what you want to protect your airways. Whereas in cystic fibrosis, you see that it forms this very sticky material that cannot be cleared from the lungs. Now, the unraveling of these disease mechanisms actually allowed to identify 3 small molecule compounds, tezacaftor, elexacaftor, and ivacaftor, that were identified by functional high throughput screening, and that can, by binding to the delta F508 molecule, correct it in its folding and maturation and function at the cell membrane so that the CFTR chloride function can actually be restored. And it was, I can tell you, it was very exciting that when a couple of years ago we had the opportunity to conduct the first large clinical trial in several hundred of patients that had one delta F508 mutation, one allele, and another mutation on the other allele that we knew does not respond to this pharmacologic therapy. And as you can see here, compared to the placebo group that we had to control the efficacy, we found a very fast and sustained improvement of lung function at a level that has not been observed with any of the other therapies before. Using MRI imaging techniques that allow to visualize mucus in the lungs, we were also able to show that this therapy effectively removes mucus from the lungs. And using quality of health questionnaires, we're able to show that the therapy comes with an unprecedented improvement of the quality of life, so that our patients can now really make new plans for their lives. So based on these results, the two big regulatory agencies, the FDA and the EMA, have approved this triple combination therapy for patients with cystic fibrosis with at least one F508del mutation, so that we can now treat up to 90% of patients with 3 pills per day at the moment from the age of 6 years and onward, but our goal really is to bring it also to the younger affected children. So this is a real breakthrough in medicine, but you have heard of rare genetic diseases before, and with respect to potential societal impact, I do want to make the point here that what we have done and learned from cystic fibrosis could now also be translated and actually used as a blueprint for drug discovery and development for the approximately 8,000 other rare genetic diseases that we currently know of, many of them with very limited therapeutic options that collectively affect millions of people worldwide. But before I finish, I also want to go back to what this means to people with cystic fibrosis. And I again want to show you the lung function of Eva Bonsack. And as you can see here, lung function was pretty unstable, going up and down. And then she went on the therapy immediately when it became available. And you can see a fast improvement and stabilization, almost a doubling of her initial lung function. So she's much closer now to this lower limit of normal of 70%. And it's my real pleasure that Eva is actually in the audience today, and I would like to invite her on stage now that she can So Eva, maybe we start and you can briefly tell us, what you experienced, what your life was like before you started the therapy.
Yeah, I will do. So, yes, as you could see in the video, I was always out of breath. It was a different life. I had to take maybe up to 30 pills per day, maybe more. I was always tired. I had to rest a lot. And unfortunately, I had to stop working because the strain was too much one day. And I didn't have enough energy for my family, especially for my son. He was 3 years old at this time. And I wanted to carry him. I always had to ask Edgar's dad to help me. And even playing with him was a huge effort for me. So actually, it was a quite sad situation for me as a mommy.
Yeah, thank you. And really thank you for coming and sharing this. So how did it change when you started with the triple combination therapy?
Yeah. So after 4 weeks, I had so much more energy for me and my family. I only need the half of the pills at the moment, and I could start to work again for a few hours per day. This made me very happy, and but after the start of the treatment, I was able to carry Edgar by myself, and today we even do sports together. So we brought you a short video to show. Thank you. Thank you so much. So we brought you... Oh. Yeah.
Thank you very much for sharing this, Eva, and thank you for your attention, and be happy to take any questions after the symposium. Thank you.